On this episode of the ASC Podcast with John Goehle, we discuss the latest news and information, review the regulatory impact over the past year on ASCs, discuss required Department of Transportation training related to regulated medical waste, and in our focus segment, continue our Accreditation Organization Series with an interview with Noel Adachi, Chief Executive Officer for the Accreditation Association for Ambulatory Health Care, or AAAHC.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServ, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Health Care Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 271 of the ASC Podcast with John Goehle, recorded on March 10th, 2026, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Health Care Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Health Care Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry and is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So, Sue, we're recording this back in the studio. You and I were on vacation last week, and we had these dreams of actually getting 2 episodes out. But how many did we get out, Sue?
Exactly 0.
Exactly 0, yeah.
We did do a recording.
We did, yeah. We actually were able to get a recording with DNV. Wonderful recording, by the way, as part of our accreditation series. We have 2 series going on right now. One is the Accreditation Organization Series. As everybody knows, there's 5 accrediting organizations that serve the ASC industry and are able to do deemed status surveys, which means that they can do Medicare certification and recertification surveys in addition to their accreditation surveys. We started the series with Quad A, which is the third largest provider of accreditation services in the ASC industry, and that was last year that we started that. Then we did ACHC, which was most recently in February. They are number 4, in other words, the 4th largest of all of them, but they're growing very rapidly. And today, of course, we're going to have an interview with AAAHC, which is the number 1 provider of accreditation services in the ASC industry. And Noel Adachi and I had a wonderful interview about a month ago, where we really, she was quite passionate, wasn't she, Sue? I think that was kind of what's been interesting about all the people that we've interviewed, is that really there's been a lot of passion in what they do for a living here. So I was very impressed with that, and we look forward to that interview. Unfortunately, the Joint Commission has decided not to participate in our accreditation series. It's not a big surprise, Sue. They're a big organization. I know you reached out to them a couple times. There's a little bit of a bureaucracy involved, and they are, they're number 2. They provide the second largest number of accreditation organizations. But we have had a problem over the last 6 years in trying to get a hold of anybody to work with us on that. And I don't don't blame them for it, but kind of disappointed, and hopefully maybe some people are listening from the Joint Commission and will reach out in the future. But we would be glad to have them on. But we are going to end the series with DNV in a couple weeks, and I think the series has been great. It's a good way to kind of get a feel for the differences in the accreditation organizations and to try to help our listeners to determine which of those accreditation organizations might be the best fit for them. Mm-hmm. We're also doing a series on artificial intelligence, and the first episode was an introduction, and we're going to continue that series throughout the year. And we're very excited. There's a lot going on in artificial intelligence. We know that the new AAAHC standard revision includes a whole section on artificial intelligence. And if you are AAAHC accredited, I encourage you to look at the press release, which included a list of all the new standards there, and to make comments on them if you have anything to say about that. We have reintroduced our boot camps. Our Director of Nursing boot camp is going to be April 7th through the 10th, and our Administrators boot camp is going to be May 26th through the 29th. The virtual component of that, in other words, the 4-day virtual conference is on those dates that I just gave you. But remember, if you are participating in the boot camp, it is much more than just that 4-day conference. It includes, optional weekly drop-in sessions where you can interface with the speakers for the conference, ask questions, etc., as well as access to a huge database of information. So we encourage you to look at that. We'll provide links in our show notes to be able to sign up. I think it's a very reasonably priced program that really helps people that are both new to the ambulatory surgery industry and new to the positions, as well as people that are experienced and maybe just want to get that extra bit of information to be able to be even more successful in their job. And we continue to really be impressed with our drop-in sessions, which this last week we moved it to a Monday. And I think we're going to be doing a Friday coming up soon, too, where we actually often have up to 4. Sometimes at one point, I think we had 5 surveyors on a session. That's really at one point, the surveyors actually outnumbered the participants because it was one of those slow days. A lot of good information is shared. Even if you don't have questions, just listening to the surveyors talk among themselves is always very interesting. So, Sue, you had a couple news bits to go over. Why don't we start with that?
Okay, so both of these articles are from Beckers. On January 2nd, Beckers published the 10 biggest disruptors to ASCs to prepare for in 2026. And there was a lot of good information in the article, so I'm just going to mention a few points. Not surprisingly, the anesthesia workforce shortage and declining reimbursement rates are expected to persist. According to a white paper from Medicus Healthcare Solutions, more than 17% of current anesthesia providers are nearing retirement, and over 56% are older than 55. As the supply of anesthesia providers declines and demand increases, which is, of course, driven in part by an aging population, the U.S. could face a shortage of nearly 8,500 anesthesiologists by 2037. The article also highlights significant shortages among CRNAs, projecting a deficit of approximately 12,500 by 2033. Representing nearly 22% of the current CRNA workforce. And depending on the size of your center, this next point may be good news for you. Although there are recent trends toward consolidating with larger health systems and larger multi-specialty centers, the smaller ASCs are often more efficient and adaptable, which can make them more successful and profitable. In a survey of 590 ASCs from 2023 to 2024, HST Pathways found 2 OR ASCs averaged a 22% increase in year-over-year revenue, while large 15-plus room ORs reported a decline in revenue of 8%.
I find I have a comment, of course, on both of those articles, Sue. Let me just start with the last one there. I'm not really surprised. I think small operations tend to be able to move quicker. Mm-hmm. Turn on a dime, and to react to the market much better than the larger ones. And I think there is this perception, which is not always true, that the larger you are, the more efficient you are. And I think the opposite is true. Just look at our hospital friends. Certainly they don't do things better than we do, as we've been able to prove over and over again. And of course, the anesthesia crisis is clearly a crisis now. There isn't a day that goes by when we haven't had a conversation with one of our clients or one of our listeners about the problem there. And I really would encourage the state associations out there to really jump on this matter for the sake of their members. And I'm not sure all the state associations are taking it as seriously as they should as part of their planning for the upcoming conferences. And also, since there's so many things that the state associations can do legislatively, or to encourage legislative action, I think that's another area that they can help in. Sue, those numbers were shocking. We're talking over 21,000 anesthesiologists and CRNAs that we're going to be short.
And we're already
middle
in
of
a
next
bad
century.
place.
Yeah, and we're already in a bad place, right? Yeah, that's a very good point, is that that's the future, not even right now where we are. And, we've talked about this before. I did want to emphasize that we are starting to see an increase in the number of surgery centers that are asking questions about conscious sedation, RN-administered conscious sedation. And while we've said this before, if you're going to delve into that, recognize that there are some real pitfalls. And maybe we'll try to get a speaker on the podcast in the near future where we talk about what you should be doing in order to prepare for nurse-administered conscious sedation. We've talked about this actually in one of our recent drop-in sessions for our patron members, where some surgery centers, think that all they have to do is their nurses have to be ACLS certified in order to be able to do conscious sedation, and that is not, of course, not the case. So something to watch out for. I think you said you had another article too?
And another common challenge is staffing, both recruitment and retaining current staff. Jane Winery, COO and administrator of Wellbridge Surgical in Indianapolis, Indiana, had some good comments on how to compete with higher paying employers. Her center does try to pay as well as possible, but works more on other benefits to attract and keep staff. They give their staff the ability to self-schedule and coordinate with their teammates to make sure the center is appropriately staffed, but this allows them to work around their family and other commitments or appointments. They're given the ability to be flexible during the day to leave for appointments when possible, and they give generous time off and holiday packages that increase with time. They also focus on building a strong team environment with leadership working alongside staff when they're needed. And I think those are really some good ideas.
Yeah, again, we need to be better than the other alternatives out there. Hospitals are getting more and more difficult, as we've heard with regard to some of the strikes recently in hospitals. And if we can provide a friendlier environment, it's not always about money, too.
Yeah. It's a big part of your life.
Yeah,
so
it is.
If you're unhappy, no amount of money is probably going to make it better.
That is so true. Well, look at your own life, Sue. You went from working in the hospital to working here. And that hospital, you were working very, very long hours. And it was not always a fun environment for you. So I think we always need to work on that. And that's something that we talk about in a lot of the state association meetings. But I think we probably should talk about that in the future, too, on the podcast, see if there's some other suggestions we can make. And I think there was another article that you had from Beckers, too, right?
Yes, I have one more from Beckers, and it was titled The ASC Policy Whiplash. So over the past 18 months, federal and state policy changes have significantly reshaped how ambulatory surgery centers are paid, regulated, and taxed. So I'll just kind of go through the list. Medicare payments and reimbursement. CMS increased ASC payment rates by 2.9% in 2025 and 2.4% in 2026, but they tied those increases to quality reporting compliance. ASCs that fail to meet the reporting requirements face a 2% penalty in their payment. CMS also began allowing separate Medicare payments for certain non-opioid pain management drugs and devices under the No Pain Act. I was just reading a little more about that, too, so that's a really good thing. We have to move away from opioid pain medication when we can.
And there's a lot of options that are available, and they are somewhat expensive, which is why CMS is allowing reimbursement.
Yep. Expanded covered procedures. CMS continues shifting procedures from hospitals to ASCs. In 2025, CMS added 32 new procedures and 33 previously non-payable services to the ASC covered procedures list. In 2026, CMS will remove 285 procedures from the inpatient-only list and add 560 procedure codes to the ASC list. Many of those are for musculoskeletal care. And the prior authorization pilot started in late 2025, so CMS launched a 5-year voluntary prior authorization demonstration in 10 states. The program will apply to select high-cost or high-utilization procedures, including epidural, steroid injections, nerve stimulator implants, vertebral augmentation, and lumbar decompression, using a combination of AI tools and clinical review.
And Sue, I noticed that the article also talked about some changes in the certificate of need, and we as a Ambulatory Health Care Strategies works very closely with many surgery centers that are looking to get a certificate of need approved. So several states have opted to start easing or revising the CON requirements. For example, in Georgia, they removed capital spending thresholds, expanded exemptions for single specialty ASCs, and allowed some hospital physician joint ventures that are under $5 million to not require CON review. Iowa exempted cosmetic, reconstructive, and plastic surgery services at licensed ASCs from the CON rules. Tennessee is phasing out the CON requirements for ASCs by December 2027, a complete removal, while requiring non-hospital ASCs to participate in TennCare, which is their Medicaid program, and provide charity care. And North Carolina upheld its CON laws with a court-rejected claim that the system creates unconstitutional monopolies. So again, they're not going away, but there's definitely some changes afoot with regard to that. Mm-hmm. And then with regard to state licensing and oversight, Massachusetts expanded the Department of Public Health's authority in January 2025, increasing their oversight of outpatient procedures and healthcare transactions. And the state also authorized licensing requirements for office-based surgical practices performing liposuction or procedures using more than minimal sedation. And we are seeing that trend in many other states. New York, for example, has required it for quite a period of time. And unfortunately, state taxes and assessments are still out there. New Jersey revised their ASC assessment structure effective July 1st. The state lowered the assessment rate 2.95% to 2.5% and eliminated the $350,000 annual cap, which I think will have a big impact in many surgery centers. And they expanded the assessments to ASCs earning under $300,000 in gross receipts. And beginning in 2026, one-room surgical practices will also be assessed, raising concerns about financial sustainability for those small and high-volume centers. And again, this is in the state of New Jersey. So a lot of stuff happened in the last 12 months in the regulatory environment. And with that, I thought I would mention something that has come up recently. And so I don't think we've talked about this, at least recently. I'm not sure if we have talked about it. It hasn't been in a couple years. And that is regulated medical waste training. So this is a rule that's been around for a very long time. So the Pipeline and Hazardous Materials Safety Administration, the PHMSA, under the Department of Transportation says that anyone who directly affects the safe transportation of hazardous materials, and yes, regulated medical waste is classified as hazmat, have to be trained. So again, if you directly affect the safe transportation of these hazardous materials, you're going to have Department of Transportation training. And that includes our OR techs or environmental services staff who package sharps containers or even line biohazard bags, or slap on the labels or sign the manifest when the hauler shows up. So here's exactly what the law requires. And by the way, this is in 49 CFR 172.704 if you want the exact requirement. Again, that's 49 Code of Federal Regulations 172.704. And this is what they require. So there's 4 core training pieces. General awareness, what is hazmat and why the rules exist. Function specific, how to properly package, mark, label, and offer your regulated medical waste. Offering meaning providing it to the people that pick it up. Safety, in other words, how to handle an emergency response, PPE, and spill procedures. And security awareness, how to spot and report threats, security threats. So the timing of this, new or newly assigned employees must get this training within 90 days. They can work under direct supervision until then. And recurrent training has to occur every 3 years. And for record keeping, you must keep the name, date, trainer information, materials used, and assigned certification for 3 years after the last training and 90 days after the employee leaves. The penalties are steep. I'm not absolutely sure about this, but I believe they're well over $70,000 per violation. And surveys or audits can ding you if they catch you. The bottom line for ASC leaders, if your team touches regulated medical waste before the hauler takes it away, you need to have this training. It's not optional, and it's not just for big hospitals where you would expect these regulations to occur. And it's actually pretty straightforward and inexpensive to do this training, especially if you do it online. You might want to check with your waste vendor first. Many bundle compliant training with their service. Or you can grab a quick course from a couple organizations out there. I think Lion Technology or Hazmat School are two that showed up in a quick Google search. So make sure you do it right, document it, and then you'll be protected. And I'll provide a link to the actual training requirements from the Department of Transportation. So I did a survey recently, and again, the issue of lapsed credentials came up. I know we keep talking about, we're probably beating a dead horse here on this, but I do want to really emphasize how important it is to make sure that somebody out there in your organization is making sure that every provider that is doing cases has credentials that are current.
I think it's sometimes just not keeping a spreadsheet or, when the time just gets away from you, but you really have to keep track of all of that.
And make sure that you're following your state regulations with regard to the timing, whereas CMS and the accreditation organizations allow you to go as long as 3 years. There are a number of states that, as part of their regulations for their licensing, do require more frequent privileging of the providers.
And there's particular timing with the credentialing and the privileging, and we have a good training that could be helpful with that.
Yeah, and I think it was in 2024 we did a day-and-a-half training program that's available on our ASC-central.com website if you want more information about how to do credentialing and privileging as well as peer review properly. And another issue that came up recently, not myself, but one of our life safety surveyors had a situation where one of the centers that he was surveying had a separate waiting area that was outside of the surgery center. And what they were doing is the patients would come into the surgery center, would sign in, the patient would register, and then the patient was sent outside of the surgery center to a common area in the building. In other words, there's a multi-tenant building to wait until they were called back in. The problem with that is once a patient is registered, they are under your care, which means that one of your staff members needs to be monitoring them. So I don't think this happens frequently, but it would just happen in one of the recent surveys from one of our life safety surveyors. So just a little thing to note. So, Sue, we're continuing our accreditation series with this episode, and this is our third in the series, and we're interviewing AAAHC. AAAHC is the largest provider of accreditation services in the ASC industry, and we had an opportunity to interview Noel Adachi. So let's take a short break, and when we come back, we'll have that interview with AAAHC about their accreditation services.
Every ASC professional knows that running a surgery center takes knowledge, skill, and a strong support network. That's why we created ASC-Central.com, a place where ASC leaders and staff can learn, connect, and grow together. ASC Central is a comprehensive hub for education and professional development in the ambulatory surgery industry. Our leadership bootcamps, on-demand conferences, and membership programs are designed to meet the needs of administrators, nursing leaders, medical directors, business office managers, and anyone committed to excellence in outpatient surgery. Our leadership bootcamps are guided, mentored programs that help develop the next generation of ASC leaders. Whether you're new to your role or looking to refine your skills, these bootcamps provide the structure and insight you need. And many of them offer AEU credits for CASC certified administrators and IPCH credits for CAIP certified professionals, supporting your ongoing professional certification. ASC Central's on-demand educational library gives you access to in-depth programs on compliance, quality improvement, infection control, credentialing, finance, and more. These full-length virtual conferences are designed to be both informative and engaging, not just check-the-box webinars. Many also include CASC and CAIP continuing education credits. For those who want ongoing learning and connection, ASC Central offers flexible membership programs. The patron membership gives you access to Zoom discussions, key conferences, and a robust resource library. The Premium Access membership adds full access to all boot camps, private consultations, staff training, exclusive content, and ongoing support from top experts in the ASC field. If you want to be part of a community dedicated to raising the bar in ambulatory surgery, visit asc-central.com or email us at info@ascpodcast.com. ASC Central, bringing ASC professionals together to learn, grow, and thrive.
I'm here with Noel from AAAHC. Noel, why don't you introduce yourself to our audience?
Well, thank you, John. I'm Noel Adachi, and I've had the privilege of serving as President and CEO of the Accreditation Association for Ambulatory Health Care, AAAHC or AAAHC, for the past 8.5 years. This has real meaning for me. It's been a real joy this past 8.5 years. As you all know, ambulatory healthcare, it's personal. It's what we engage in every day, myself, my family, and it goes across primary care, specialty care, and procedural care. It's how we interact with healthcare most frequently, and that's why I really enjoyed this opportunity. But what makes it particularly meaningful to me is the opportunity to work alongside an extraordinary headquarters team, a knowledgeable and highly engaged board and volunteer committees, and a fantastic surveyor workforce. Our surveyors are passionate, they're driven, they're educators, they're continuous learners, and they're deeply, deeply committed to advancing patient safety and quality improvement. As you know, John, at AAAHC, our philosophy is 1095 strong, quality every day. And we focus on partnering with organizations to strengthen care delivery, effectiveness, and outcomes across ambulatory healthcare. Past 8.5 years has gone by so quickly, and it's just been a joy. Not a boring moment.
Yeah, that's for sure. Especially your 8 years here, of course, has been a lot of changes.
Great.
There is a full disclosure here, of course. I am one of the AAAHC surveyors. I can't say that for any of the other organizations, of course, that we have had on the podcast here. And, of course, I've enjoyed my time. I've been off and on as a surveyor. I'm not absolutely sure. Someday I'll actually look it up, but I think it's about 23 years now. So, and it's been a great pleasure. And I know what you mean. That the staff you have is absolutely incredible, and they do a great job. They keep me in line, of course, when I do a survey, and that's very important. Can you?
I just looked at your history, John. I looked back at how many surveys you've done, but also your deficiency rate to see, what type of surveyor you are. Pretty good.
Oh, that's good to hear.
Thank you.
Why don't you talk about history? Why don't we tell us a little bit of the history of AAAHC?
We were incorporated in 1979, so we're about to celebrate our 47th birthday. We started with 6 charter members, which included ACHC, American College Health Association, the American Medical Group Association, and all of these in their previous names.
Right.
ASCA, of course, what had a different name. American Association of Health Plans, MGMA, Medical Group Management Association, and the National Association of Community Health Centers. So these 6 founding organizations served as establishing our charter and moving us forward. And that worked for many, many years. It was a model called pay for play, where associations paid to serve on the AAAHC board, which meant that it worked pretty well for many, many years, but it also meant that people were there specifically advocating for their specialty. And over the years, the board recognized the need to evolve AAAHC. And in 2017, at that time, we had 31 board members of all these different, over a dozen interested ambulatory care or organizations that had a vested interest in ambulatory care. The board recognized the need for change. And in 2017, we took action on that and officially changed our bylaws and our whole governance structure effective in 2018. So that's what I walked into. It was the opportunity to really shape how we move forward, and that was really exciting. And today, we've accredited more than 7,000 facilities. We are the number one accreditor of non-CMS certified, or CMS certified, accredited by AAAHC ambulatory surgery centers. So it's, and we continue to expand in primary care as well. So we are the number one accreditor of ASCs across the board, whether they are for purposes of deemed status or not.
Noel, I've just within the last year, I've gotten involved with the, some of the committees of AAAHC. Why don't you tell us a little bit about the committee structure and how that supports the efforts and the work of the organization?
Sure. Our committee structure, again, with that change in 2018, we structured numerous committees to help us better focus on different aspects of ambulatory care, as well as our surveyors and client education. So we have over 100 individuals participating in our governance model, including the board. And all of these people are actively engaged in the ambulatory community. Mm-hmm. So we have a whole, as deemed by or designated by our bylaws, we have an accreditation group that makes the accreditation decisions and operates on behalf of the board. That's our largest group of cluster of committees. And they meet, we have accreditation committee meetings going on every week. We also have a standards development cluster that focuses on different segments of ambulatory care, obviously Medicare, health plans, primary care, and advanced orthopedic certification. And then we have an overall standards development committee that ensures that our standards are developed align with our policies and procedures to ensure consistency, quality, clarity, and manage the public comment process that we do every time prior to releasing substantively changed standards. We also have an education committee that focuses both on surveyor education and client education. And a key part of that committee is making sure there is alignment, that we're not teaching our surveyors something that we're not also open book sharing with our clients, so that they're lockstep understanding how we go about doing what we do. We, with launch in 2018, introduced an accreditation cycle management committee to look more holistically at the entire space of the 1095, everything from the application process all the way through to intra-cycle activities like interim surveys or annual attestations. Let's see, who am I forgetting? Oh, yes, importantly, the Institute for Quality Improvement. The Institute used to be a subsidiary of AAAHC and then was rolled into the committee structure. And they're responsible for benchmarking studies, toolkits, the quality roadmap that provides the annual update on deficiencies, common deficiencies. That's a really great resource as you're preparing for your next survey or your intra-cycle gap assessment, and other white papers and more ahead of the standards development side of the house. We also have a surveyor advisory committee that focuses on how are our surveyors doing? How are we ensuring inter-rater reliability, for example, in between surveys? What education do we need to focus on? How are we evaluating and recruiting our surveyors? And do we have enough surveyors to cover all the needs that we have as we continue to grow? But it's a great process, and this body helps elect the board directors. So all of the directors, because we're not a traditional professional medical association, and our directors therefore are elected by this body of individuals who essentially govern the organization.
And I just had my first meeting of the EDC, or the Educational Development Committee. And Noel, earlier in the day, this was yesterday, early in the day, I was meeting with one of our clients who, unsolicited by me, was raving about the education program that she had gone through.
TV accreditation program, it's our flagship conference that we do 3 times a year. Our faculty are all experienced surveyors in both surgical and primary care. We've evolved the program. Interestingly, COVID forced a lot of change on all of us, right?
Yeah.
We moved forward with a virtual version of Achieving Accreditation that we actually hung on to for our summer program in September. It's a 3-day program, and it has the largest attendance because it's convenient.
Right.
For some folks that can't travel or don't have the budget to do that, it's a really great opportunity. And technology has allowed us to be even more engaging through virtual delivery. And I mean engaging the participants talking to each other,
Yeah.
Which is where most of the learning happens, right? It's when you talk to your colleagues. And as much as healthcare is a huge industry, what I've found is that the community for ambulatory surgery centers, for example, it's pretty tight. People know each other and they enjoy the opportunity to learn about what's going on the other side of the country. So our education provides that mechanism to not only learn from our faculty, but also learn from your colleagues, which is so, and you know, John, you're an educator.
Yep.
You know this well. Your boot camps do the same thing. It's not just what you learn from the person up on stage. It's what you learn from the interaction with others.
Yeah, and that's really what is quite engaging about our boot camps, of course, is that ability to meet every week and to talk about things, even a couple of years after they've done the boot camp. And I think that ongoing engagement is what's going to be critical. The more that our constituency can learn from each other and prepare, learning some of the mistakes, some of the things that they might have been dinged on in one organization, often a lot more effective than hearing it directly from in an education program.
And we do the same thing for our surveyors.
Yeah,
now,
that's a good point.
This year, we're not having an in-person meeting with the surveyors, but we're driving other sorts of engagement. And, the other reality is sometimes learning is best delivered not in a big audience, but in those smaller group settings. Yeah. So the virtual environment allows more of that opportunity to do it. We've been doing this every quarter with our life safety surveyors. And they've learned so much from each other, and they've provided such great, they align on feedback for AAAHC so we can improve those standards, the organization and the standards, and system enhancements that we've implemented. So it's just a great opportunity. And I can't say enough about our surveyor team because they really are passionate. It's such an interesting variety of people, but they share that common thread.
Yeah, and I think you probably know this, but behind the scenes, we communicate with each other a lot. We all have each other's cell phone number, text messages, and during a survey, often if we're unsure about something, we phone a friend or text a friend, and that's probably one of the. I love that part of being a surveyor. Is just knowing that I'm never alone when I'm on a survey.
Correct. And, for a lot of our surveyors, they are also working in ambulatory surgery centers. It's their full-time job. And they enjoy being a surveyor because they get to not only educate, but learn while they're out doing surveys as well. So any surveyor that I've talked to, you ask them, every survey they go on, they learn something.
Yeah, absolutely. Why don't you talk a little bit about where we draw our surveyors from?
Sure. We have about 270 surveyors. The majority of them are surgical. On the surgical procedural side, the ASCs and OBSs. We also have a large group of college health surveyors and others focused in the primary care space. The majority of our surveyors have been recruited from our accredited facilities that have demonstrated that they care about quality, they want to hold themselves to high standards, and they want to share their experience and knowledge with others. Typically, we're not talking about somebody who's just come out of school and has gotten into an ambulatory surgery center. These are people that have moved through the paces, if you will. They're more senior in their careers. They've been in either administrative or other clinical roles, and they have experience. They've seen a lot. And they could be in ophthalmology. They could be in GI. It's across the specialty space, predominantly nurses among our surveyor team, but we have everything from physicians to dentists to administrators, really across the board. And, what I've found interesting about our surveyor team is they hang in there with us. We never stopped during COVID.
Yeah.
We kept going. And that is a testimonial to our surveyor team and to the clients that let them in the door,
Yeah.
during that challenging time, and wanted to continue to provide care to patients. And I recognized that they had to do the very best they could to keep the standards at the expected level, right? So it's we go through a recruitment process, and we do a panel interview with our candidates, because it's not just about the knowledge they bring, it's about the personality, the style, the behaviors. Because if you want to teach somebody, hammering them over the head is not the way to do it. And having that empathetic ear and listening and identifying opportunities. It's not about a gotcha.
Mm-hmm.
It's about what are you doing and how does it comply and how can we help you get to the next level.
One question that I'm sure some people in our audience are wondering right now is, are you recruiting today? We are recording in February of 2026. So people are always asking me that question.
So we started recruiting every year post-COVID.
Mm-hmm.
And part of it speaks to the longevity of our surveyors. And at some point, some of them are going to find more things interesting, like grandkids or other things in their lives, taking care of their health or whatever. And as we continue to grow, we need to make sure we're replenishing our surveyor team. So we are recruiting right now, and it's available through our website, careers on the careers page of our website. We're looking particularly for West Coast, preferably physicians, because of the California requirements and the high volume of ASCs in California. Texas is always a big market for us. So we're trying to have surveyors closer to home.
Yeah.
Because that's important. They understand the state laws.
Right.
It can be changed, significantly from state to state. But it also, because our focus is on individuals who are still working in a primary or ambulatory care environment, being closer to home means less stress on travel if possible, as long as there's no conflicts of interest in the next, in the facility they go into.
Right.
So yes, we are recruiting. We're expecting our next class to be coming in June. We're doing a training event in June for our new surveyors. And, whether it's right now where we're focused on health surveyors versus life safety code.
Oh, that's good to know. Yeah. One of my employees just recently became a surveyor. She described the new process that she went through, both from the interview all the way up through she's about to be let out on her own. So, but she spoke very favorably of the way the process worked, how smooth it was, and how confident she was when she finally did get out there.
We also believe very much in mentoring.
Yes.
Right? So before we let people go off on their own, they go through a mentoring process. It actually starts with the interviewing. Mm-hmm. And I say that because I do this for headquarters staff as well, panel interviews, because I want people to have a vested interest in that candidate and bringing them along. And what I've really enjoyed, I've seen this with some of our life safety surveyors that we've brought on, the more seasoned, tenured people that are serving as mentors hang on to their mentorees. Yeah. And that network that you talked about, that's there for them. They're not there by themselves. They can call a friend. They can call the AAAHC headquarters and get answers to their questions while on site or while working through a survey report or prepping for a survey.
Noel, one of the major themes that we have with this series on the accreditation organizations is identifying what makes each of the accreditation organizations different.
Well, here's the reality. Every accrediting organization has a different personality. Yeah. Right? And, we are very much on the collegial but educational consultative approach. We are solely ambulatory health care based. Mm-hmm. That's our core. We don't venture out into other areas. Our standards are absolutely focused on this space. And similarly, it goes all the way through our board, our volunteer committee members, our surveyors. They're all brought up and through this ambulatory space. The folks that are doing surgical procedural surveys, the ASCs and the OBSs and the OBLs, these are individuals who have that experience in their work life, their full-time work life, if you will. And so they bring consultative educational approach to it. That's significantly different from other accrediting organizations. We were founded specifically for and solely for the purpose of bringing standards to ambulatory care 47 years ago. And our standards are developed in the same exact manner by professionals in the space who are knowledgeable with research of evidence. And a key aspect about it is because many of our committee members are surveyors, we have to make sure these standards are practical, that they're surveyable, that they're clear so that the person who is saying, oh my gosh, what is expected of me? That they understand what is required because they're developed by individuals who've been in their shoes. So, I see those things as some of what makes us different. I will answer the second part of your question is, our goal is solely focused on this community. That means not just our surveyors, our client education, our surveyor education, but also our system is designed for this community to gather the information that will help us curate those standards more effectively, assign surveyors more specifically, and bring more value through the process because we understand what's going on in that facility. Is it a fit for everyone? Just like anything, everybody has their own style and approach and familiarity. So what we've seen with some of the hospital-based systems that they want one-stop shop, to cross the whole breadth of care provided. That works for some, it doesn't work for others, because even though you might be under the same umbrella, ambulatory care is different than hospital care. It is. And, I was at a meeting a couple of weeks ago, and it was a mixture of more hospital-focused representatives from accrediting organizations and ambulatory. And, you think about an ambulatory space where, or you think about a hospital where you have a quality manager, you have a risk manager, you have building management people, all of these are accessible and on-site to you. You go into an ASC, the DON, what hat are they wearing today, right? And the reality is they're wearing those simultaneously. And that's the space that we operate in. We understand that challenge. So I think that's our differentiating advantage, but it also, it's going to be different for different people and different organizations depending on their prior experience and their organizational structure.
No, well, I think another thing that I see is that AAAHC probably revises its standards a little more frequently, or at least is a lot more upfront about the revisions to its standards more frequently than other organizations. Can you talk? You've talked about the process, but why you do that and how that really enhances the services that you provide and benefits the organizations.
Well, change is hard for everybody, right? Even small change. When my phone updates and I have to figure out how to swipe down or left or right, it's just an education process. But why do we change standards? And part of it more recently has been driven by the system and really the advancements in technology and practice. So when we shifted from thinking of standards as a publication to integrating them into the new system meant that the structure of the standards needed to change. We also wanted to be very thoughtful in the standards development process to make sure that our clients understood what we were looking for and the why behind what we were looking for, so that it's not guesswork. We talk about accreditation being an open book test. all the standards are there, but if you don't know what they mean, they're so vague or they're not specific to your environment, then how do you know what to do? How do you know what kind of guardrails to put in place so that it becomes part of your organization? At the same time, we didn't want to be overly prescriptive because there are a lot of ways to accomplish the same goal. So that balance between clarity and prescriptiveness to ensure that they were applicable across different specialties. And so that evolution, we continue to improve. And part of that is driven by, a large part of it is driven by data. That data is the field telling us, we don't understand this. We might get it wrong, not because we're intentionally ignoring it. We don't understand what it requires, so let's improve it. And that's why the public comment process is really an important field test. But before I get into that, we also get a lot of feedback from our surveyors. If they're hearing that clients aren't getting this, it can inform education. It can inform standards revisions. But also, and importantly, the space is changing. I mean, look at what's happening with cardiology.
Yeah.
And the other part that's changing is each state has their own set of requirements, which makes it further challenging. And then we've got emerging technology like AI, and maybe we'll get into that later. But, that's something that I'm really passionate about. And it speaks to making sure that we want to make our compliance to the standards become part of the fabric of that organization. And if COVID taught us anything, it is that you have guardrails in place for a good reason. And we saw so much turnover in the ASC space that very experienced director of nursing turned over, and you get somebody in there who doesn't have nearly as much experience. They need accreditation. They need the guidance. They need the guardrails so that they continue to do the right thing so that they can focus on the clinical care that they're delivering. So our standards, I would say like this year in public comment, we have a total, I think, 6 or 7 new standards. We're also eliminating elements because if technology practice changes or it's just not relevant. So why just go through the exercise of having something in there that everybody automatically gets 100% on?
Right. I think it is important, too, to remind our audience how important I, as a surveyor, I'm always shocked at the number of times I walk into a place and they haven't read the accreditation standards. I'm not just talking about AAAHC. I'm talking about all the accreditation organizations out there. And it makes it even more important when you do have a dynamic process for revising the standards on an ongoing basis, which AAAHC, of course, does.
And that's a really important point. So when I came to AAAHC 8.5 or so years ago, it struck me as unusual that we accredit organizations and then we charge them for the handbook. And so we don't do that anymore. And we've stopped doing that quite a while ago. We provide the handbook as part of the process,
right?
Always available to clients right through the 1095 Engage system. And we provide them the current set of standards and what's coming up so that they can always be continuously ready. We also provide them an Excel-based gap assessment tool so they can go through that process themselves, not all at once because that can be overwhelming, but as they're reviewing their policies on an annual basis and conducting training with their teams, having that tool available to them. The free education that we provide on the standards updates. We want people to understand what's changing, the why behind it's changing, and then giving them enough runway to implement those changes. And that's why public comment is also important. It gives them an early idea of what is coming well in advance, 8 months in advance of effective.
We have gone through a major change in technology within the last couple years. It's almost like the elephant in the room. I know that many of our listeners probably went through some difficult times as they were transitioning from your old system, or I should say systems, to your new one. So, and you and I have talked extensively about that process, and I've been honest with you. Certainly from a surveyor standpoint, I would say that most of us surveyors really enjoy the survey side, but the client side has been somewhat painful. So can you talk a little bit about the need to do that, why it was, why such a change occurred so, quickly, and where we are and heading in the future?
We've been working, we launched 1095 Engage in April of 2024. It has been a labor of love for me personally for more than 5 years. We actually did a lot of the system design during COVID, which is totally virtual system design, is really interesting. What struck me with our systems when I came into AAAHC was they were disconnected.
Right.
That they were largely text-based, meaning you could put anything in there. There was no data. It was text. That they were costly to maintain because they were all bandaged together. They worked well, don't get me wrong. It's just that they weren't seamless. They weren't feeding each other and providing value at the end of the day, as much value as that our systems do today. There also were a lot of parts of the process that were still manual.
Right.
So we looked at and spent a lot of time designing the system, incorporating surveyor and client feedback along the way, but also looking at how can we bring more value, like putting the handbooks right into the system and making them readily accessible. Providing surveyors an easier way to know what they've already rated and what they haven't, where comments are required, where they aren't. But most importantly, I would say one of the biggest aspects of it was the objective of the system to make accreditation a living and breathing part of the organization, not an episodic event. Not a one and done, but a 1095 every day of the 3-year cycle. And the system breathes that philosophy. Again, not a point in time event when the surveyor shows up, but really a life, the life of the accreditation. That means we needed to capture data in a more structured manner. We needed to monitor and have real controls over each stage of the process. We need to have consistency. And importantly, I needed to have a way to curate standards so that instead of saying, okay, here's the handbook, you figure out what is relevant to you. By capturing information about an organization, we could curate the standards for them, which results in a sharper focus for the surveyor and more meaningful preparation and ongoing compliance for the organization. We heard that so many times. AAAHC doesn't, in the sphere of accrediting organizations, we don't have a lot of standards. And if we can curate them to be more relevant, if you're not doing lithotripsy, why are we giving you lithotripsy standards? That sort of thing. If you're not doing a higher level of anesthesia, why do I have to even worry about these other anesthesia? If you don't have a pharmacy, because our focus, we want to focus on something. We don't want to have to figure out what it is we want to focus on. Tell me what I'm supposed to do. So by being very thoughtful in the design, by taking it every stage through the entire process, with any system, there's going to be a learning curve. We've talking about certain features of 1095 for 5 years with our clients, but we're all human. We can talk about it theoretically and say, oh, that's great, sounds wonderful. And then you put it in front of me, I'm like, oh my gosh, I don't have time to learn this, right? So we're trying to do all we can to provide education, to make resources available in person. And that's been one of the rewarding aspects that we're now seeing with the system, is that we've improved the efficiency of every stage of the process, which actually allows more time for human interaction. So we have an outreach program going on all of last year and this year, where we are reaching out to organizations more than 6 months prior to their anniversary date to work with them about through the change management one-on-one and help them get their application ready so that they're not rushing in the time they're most stressed, which is right before the application is due and the survey is right there. We're trying to build in the philosophy of the annual attestation so that you don't have to go through that rush. It struck me as odd when I started at AAAHC that organizations who have been with us for decades had to reapply every 3 years on a brand new application.
Yeah.
And by having a real living profile, I know the changes that are going on in your organization, and I can support you through them. It also means that the application process is so much easier Now, our organizations haven't experienced that renewal process yet in the new system. They're just about to do that as we head into next year. And then they'll start to say, oh, wow, that was so much easier because I maintained it. It's like anything, keeping up to date, maintaining your system when things change. So what you hear most about is getting into the system and prepping for application completion and then survey. When you're most stressed to get that done, because you got clinical care to continue to be focused on. So we're trying to get to you well in advance so that it's less stressful, that the change and the new fields that are required so that you can focus on that curated standard. I've seen an amazing adoption by our surveyors. They too went through a real challenge. They were familiar, as wonky as it might have been. Our legacy system worked well, and they were very familiar with it and experts in it. Mm-hmm. A change happens. It's like going from a Samsung to an Apple. It's like, oh my gosh, I don't know where to find my calendar. And so that's just human. And we're there to support. It was a painful process, candidly. Mm-hmm. And I'm just really proud because of the surveyors, because we have seen such great adoption. Now, I'll give you an example. One of the changes we put in place was the preliminary report. Mm-hmm. Clients said they wanted those results right away so they could start looking on their plan of corrections. And other organizations provide it before they leave.
Right.
And so I wanted to provide a meaningful, leaving point that it might not be finalized, but at least the organization can start looking at and taking action, particularly for those Medicare accredited deemed organizations. They have a very limited time to do that POC. So we brought it to the surveyors. We said, this is what we want to do. And they're like, we can't get that done. They're doing an amazing job.
Yeah.
Because they've learned the system and they are well within the window of what we're targeting, which is 24 to 48 hours. And they're also streamlined their survey reports. So our overall turnaround time has actually improved, even though for our non-Medicare clients, they now have a plan of correction that they have to submit that they didn't have to do before. We're still hitting our timelines. So change is hard. It's definitely hard. I mean, even we just had a new floor done in our garage, and I'm going to be parking on the other side of the garage. I know I'm going to have problems adjusting.
Well, Noel, I do have to say, I was one of those naysayers too. Oh yeah, I don't know how I can get the report in within 48 hours. And you were very good with us surveyors. I think the first time that I did a survey, it was 72 hours, and then 68, and then and now I'm to the point where I sometimes feel like I could push the button before I leave the center. I'm not confident enough yet to do that. I want to one last check, but I know I'm going to be there. And actually, I'm doing a survey next week with one of my dear friends who is very well known for almost always hitting the button before she leaves the site. So I'm hoping to learn from her as to how she gets that confidence to do it. But you're right. It was a lot of change, but I think that benefit of being able to see those results very quickly now is a huge change for our accredited organizations.
Understanding that it is a preliminary report, right. And the real value is when the surveyor adds that compliance commentary and consultative commentary. And we're making more use, we have plans to make more information available to clients on consultative feedback as well as to surveyors so that they can really enrich that survey report. But we're getting there. And I'm particularly happy about the fact that the efficiencies we've gained have made more human interaction possible because, learning everybody learns differently. And many of our surveyors, many of our clients just want that confidence. Mm-hmm. Walk me through it a couple times. I'll get it. And I'm as guilty as the rest. Don't give me a manual to read to teach me how to do this. Talk to me through it. Everybody learns differently. I mean, when was the last time when you got a new phone that you actually looked at the manual to figure out how to do something?
I didn't even know that manuals still existed for that.
Exactly. So it's a living system. It continues to evolve. We continue to seek feedback from our clients. I'll give you another example. We went a little overboard on the emails that go out to clients.
Yes, you did.
Constant reminders. We want you engaged throughout every moment of every day and thinking about AAAHC. Okay, maybe we went a little bit too far. So an enhancement we're working on now is to right-size the communications.
Mm-hmm.
Still be part of their life,
Mm-hmm.
but in a less annoying manner.
I did want to go back, Noel, and kind of reemphasize the first time that you apply for a survey with the new system, it's going to take you a lot longer because there's so much upfront information. But then, as you mentioned, when you go through that cycle again, you're going to find a huge difference in the application process. Even if we could call it an application process, I guess really it's just going to be that ongoing engagement that you have where you're making sure everything is ready. That final attestation before the your survey comes up, you'll feel much more confident as you go into that next survey.
But that brings me to the annual attestation. We talked a little bit about this before. Some people find it, don't like having to do it. The standards require that you're looking at your policies on an annual basis. The annual attestation also says my application is up to date,
Mm-hmm.
so that you're not rushing to do it every 3 years. It's up to date. That I've looked at the most current version of standards and I've validated that I am in compliance with them. So I think of it as an annual physical. We prompt organizations to validate their core governance and operations each year. These are embedded into their quality management processes, daily practices, and it reinforces that 1095 strong quality every day, not just when the surveyor shows up, not just when you show up, John, but every day when that patient shows up, which is what really matters, right?
Yeah.
It's when the patient shows up. And that's, the annual attestation is simply a prompting to say, yep, my application's up to date. I'm compliant. I know that I'm looking at, you commented, you're amazed that occasionally you go into a facility, they haven't looked at the standards. It's like, really? So let's make it available. Let's prompt them to do that. And it's like anything, it takes practice.
Yeah.
It's just like putting together a plan of correction. If you're doing it, and we expect that as part of the annual attestation as well, you don't have to submit it to us, but the more frequently you do it, the more it becomes part of the fabric of your organization, the better you're going to be at doing it, and the more receptive people are going to be to it. And then you can measure your progress. You can say, hey, it's sustainable. We did a good thing. And feel good about it. I mean,
Yeah.
I can take a few of those feel good things every day, so.
As we come to an end, one thing that I think we probably have to address too is what are some of the hot topics right now? Some of the areas that you see the most citations from surveyors. I talk a lot about it, but it would be good to hear what rises to the top in the organization.
Well, I've just been working on some of that data, and I don't have all of it in front of me or all the standards memorized, but I would say the number one thing has to do with emergency management.
Yeah.
And I'm talking specifically about the surgical procedural ASC, OBS space that we're talking to. Drills.
Yes.
And several elements of those drills, just making them relevant, documenting the findings, who was there, process improvement discussions, all of the elements under for V44, it's standard EMG 170. And it's got a pretty high deficiency rate on something that probably has never been more important.
Yeah.
And it's interesting. It reminds me when I was a kid, we'd have, being from Chicago, we'd have tornado drills.
Mm-hmm.
Right? You go in the hallway or into your desk or whatever. And in college, when I spent some time in Japan, we had earthquake drills that we had to learn about. Well, in today's environment in an ASC, active shooter, incapacitated physician. There's just such a bigger variety. M-house drills, whatever it is, having a knowledge of what your organization can possibly experience a flood, a fire, if you're in California. Think about what they went through this past several years. We had a facility in California that was burned to the ground during the fires, so we also had a surveyor, I don't know if you've heard this story, but I have pictures, so I know it really happened, where a surveyor was in the facility and a car came through the window Have you seen those pictures?
No, I haven't, but I heard the story.
Oh, no.
Yes.
Yeah, and I've seen them, and
Yeah.
but the other aspects that are what's new on and coming forward is cybersecurity.
Yeah.
What are you going to do? And this is at AAAHC as well. It's everywhere. What happens if there's a breach? How do you ensure? For example, one of the things we're really emphasizing with our clients is don't send us PHI.
Yeah. Right.
Where, somehow it was in the application, or it was in the plan of correction, or if they had an immediate jeopardy, it was in the removal plan. We don't want your PHI.
Right.
We don't want your PII, right? Patient health information or personal information. So on your plan of correction, don't put the person's name. Put the role that they're in, because that also is sustainable. Because if that person changes out, you at least have designated the role that's accountable.
Yeah.
And so cybersecurity is an important factor, and never more important than it is now with AI making its full stage appearance, right?
Yeah.
It's already embedded in scheduling and documentation and decision support. And the reality is, every one of us, some way or another, unless you have your head in the ground, is using AI.
Yeah.
The moment you do a Google search.
Yeah.
Right?
You can't avoid it anymore. Yeah.
You can't. And I think I told you this story about when my husband took a picture of my new son-in-law and my daughter and put their pictures into AI and came back with what our grandkids would look like. Now, that might be a little overboard.
Yeah.
They're going to be
We don't need to
gorgeous.
see that.
Knock on wood that I'm blessed with grandchildren. But, I'm like, and both my kids were like, Papa, please do not put our pictures on the internet. Okay. So, that's the reality we live in. It's so easy, and it's so easy to mess up. The other part is that in the public comment that's going to be released here next week, February 26th, we want to make sure that everybody sees what we're talking about with regard to AI.
Yeah.
And the range of AI that facility uses, that's how we needed to make sure with the standards that we're not saying you got to use AI.
Yeah.
We're not saying that at all. We're saying use it responsibly, know where you're using it, making sure the governing body is aware of it and people are trained on it in whatever aspect you are using it in.
Mm-hmm.
We do it in infection control. We say do a risk assessment, right? Well, similarly with AI, little things can go wrong or big things, depending on how you're using it. So be prepared for that. I'm sure that both of you, and Sue, you're on the phone here, that have used AI, and you put in a prompt, you get back a response that has nothing to do with what you asked.
Yeah.
It's like, okay, close, but no cigar, right? So
totally misunderstood the question.
Let's try that again, right?
Yeah.
And every AI thing, it says, this could be wrong.
Yeah.
So we never want to get away from the human element, especially in care delivery. It's just, and you look at the big systems that EHRs, they're using AI.
Yeah. I think that's a good thing to emphasize, is that a lot of the changes in the standards, the proposed standards, have to do with AI. And I just want to remind our audience too, we are launching very shortly a full year series on artificial intelligence, which will help our surgery centers and our listeners to understand the various roles that it will have in surgery centers. But it's great to see. And I believe AAAHC is the first one to really start to identify standards related to AI, and I think that's going to really set the standard for the industry moving forward.
Next week, pending board approval, we release our public comment. It's open for 30 days. All of our clients will receive an email inviting them to participate in it, and I am putting a plea out through you, John, that yes. I want every surveyor to comment. I want every client to comment. We look at everything. Mm-hmm. We look at that feedback because we don't want to add burden, but we also want to ensure that the proper ethical use of AI in healthcare, and to the range of applicability where it's relevant. So it runs through March. And we're anticipating these changes will be released with version 45 that's expected in mid-August of this year. So we want to hear this is our opportunity. This is our opportunity to shape the standards. And we really hope that people use that and also see it almost as their responsibility, because it directly impacts them, and it is helping them shape healthcare. And that's what I started off with. This community is actually small and critically important, and everybody's voice is meaningful to me.
Well, we'll certainly mention it in our show notes. And, of course, whenever new standards come out, we do tend to talk about it during the podcast. We'll make sure that we talk about that. Noel, this has been fantastic. It has been a couple years since AAAHC has been on the podcast, and it's been great to connect with you and to show exactly what AAAHC is all about, and compare this organization to AAAHC to the other organizations that we're looking into as part of this series.
Well, thank you, John. This is I enjoyed talking with you before, but this has been fun, and I think you're sort of a professional at this. I think you've done this before. So thanks for making me feel at ease. And, I am passionate about this. I hope that came across.
Yeah.
And, to me, it is about a partnership.
Yeah.
We take action on feedback from our clients and our surveyors to provide that continuous improvement in our standards, our systems, and the support we provide. And I mean it. I want feedback. I want people to continue talking to me. So thank you for this opportunity.
Absolutely. And we are going to be talking to you and your staff again. We do try to, on an annual basis, or at least want to get back to an annual basis, talking about the various findings from surveys, because that's one of the more popular issues that we talk about on the podcast, is what preparing people for a survey and identifying opportunities for improvement moving forward. So
with the new system, we have more access to that data more real time instead of waiting a year. So when we talk next, let's talk about that.
Sounds good. Thank you so much.
Thank you, John.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So as we mentioned earlier, the virtual conference component of the ASC Director of Nursing Bootcamp is going to be April 7th through the 10th. And for more information, visit asc-central.com. And we'll provide a link to the website in our show notes.
And AORN's Global Surgical Conference and Expo is April 11th through the 14th in New Orleans, Louisiana.
And the American Academy of Ambulatory Care Nursing, or AAAHCN's annual conference is going to be April 14th through the 17th, 2026, at the Hilton Orlando in Lake Buena Vista, Florida.
The ASCA and SAMBA Conference and Expo is May 13th through the 16th, 2026, in Washington, D.C.
And we're going to be there with a booth, and we'll, of course, be recording at least 2, hopefully 3 episodes while we're down there. Looking forward to the conference this year, and I think I'm actually doing 2 sessions. First time I've done 2 sessions for ASCA in a number of years. And the virtual conference component of the ASC Administrators Bootcamp is going to be May 26th through the 29th, 2026. And for more information, again, visit asc-central.com.
And the Gulf States ASC Conference, which includes Alabama, Louisiana, and Mississippi, is June 17th through the 19th. At the Ritz-Carlton in New Orleans.
The Arizona ASC Association's conference is going to be June 24th through the 26th at the Sheridan Grand at Wild Horse Pass in Phoenix, Arizona. Sue, I think you just got me my plane flight for that trip.
Did.
So I'm actually doing 2 sessions there this year, including one of which is going to be a workshop. The Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 22nd through the 24th at the Hyatt Regency Grand Cypress in Orlando, Florida.
And the California Association's annual conference and exhibits is September 2nd through the 4th in Monterey, California.
The Pennsylvania Ambulatory Surgery Association's annual meeting and educational conference is October 4th and 5th at the Eden Resort in Lancaster, Pennsylvania.
The Atlantic States ASC Conference, which is North Carolina, South Carolina, and Virginia, is October 8th and 9th at the Embassy Suites, Raleigh-Durham Research Triangle in Cary, North Carolina.
The Ohio Association of Ambulatory Surgery Centers annual education conference is November 11th and 12th at the Ohioan Hotel and Event Center in Lewis Center, Ohio.
The Washington Annual Education Conference and Trade Show is November 11th through the 13th at the Tulalip Resort and Spa in Tulalip, Washington.
And Sue, that's going to be a problem for me. I'm usually at the Ohio Association and Washington Association meetings, and they are being held at the same time.
Yep.
This year. So we're going to have to figure out how we're going to handle that. And the New York State Association of Ambulatory Surgery Centers Conference is going to be November 17th through the 18th, 2026, with the pre-conference on November 16th. And this is going to be at the Desmond in Albany, New York. On-demand versions of the ASC Director of Nursing, ASC Administrators, and the ASC Business Office Managers Bootcamps are available on our sister website at asc-central.com. And just a reminder for everybody, I know we keep talking about this, but the patron member program is available to anybody, and it's available on asc-central.com. And through this, you gain access to a lot of great tools. The comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation, compliance, operations, and financial management. It's designed, to take into consideration the busy schedules of administrators, nurse managers, and business office managers. And by becoming a member, you gain access to our regular, usually weekly Zoom sessions. They are held sometimes on Saturdays, sometimes on Mondays, sometimes on Fridays. We do move them around a bit, and that's on purpose. We want to try to capture as many people as possible. You'd be surprised at how many people show up on a Saturday, even though it's a work day. That is sometimes our most attended conference. And of course, on those drop-in sessions, you can engage with other patrons and our podcast team, as well as a number of surveyors that show up. But that's really just the beginning. Your membership unlocks a wide range of resources, including access to a number of our virtual conferences, which include the credentialing conference that we mentioned earlier, the Conditions for Coverage conference, and also there's other valuable tools such as sample policies, procedures forms, and fire and disaster drill kits. Your support of the patron program helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit asc-central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here at the podcast, our sound editor, Sue Cronkite, executive producer, John Goehle, and our committed research team of Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, and Christina Norman. Your hard work makes this podcast possible. Our theme music is by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you on the next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Health Care Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.